You ready? Let's do this. Well, welcome back to the GROklahoma podcast, and this is Dr. Ogunsoya, and today I have a guest on the show, and super excited for this opportunity to share her story. She completed her allopathic medical education and master's in public health with a focus on epidemiology at the University of Oklahoma Health Sciences Center here in Oklahoma City. This is about 6 years ago. After then, she completed her general psychiatric residence training at Louisiana State University in Shreveport, Louisiana. She's also since practiced in Illinois and Tulsa, Oklahoma, where she's currently based at the Oklahoma State University Center for Health Sciences. Her clinic duties are based on at the Tulsa Center for Behavioral Health, which is a state-operated facility here in Tulsa. And since completing her training in general psychiatry, she's finding herself wanting to re-engage with research career. So that's definitely something we plan to explore on today's podcast episode. Her research interests include treatment refractory psychotic symptoms, particularly delusions in individuals with schizophrenia. She's excited to collaborate with folks across institutions, especially those involved with the OSCTR. Please join me in welcoming Dr. Noeen Sarfraz to the podcast. Hello, Dr. Sarfraz.
Hi.
All right, so let's just get started from the fundamental questions. Just telling us, your journey. Where were you born, and how did you find yourself in your current role? Yeah.
I was born and raised in Lahore, Pakistan, and then as a family we immigrated to the United States. I was the first one to stay and complete my education, and then my family later all came. I did my undergraduate in the Northeast, and then came to Oklahoma, got my medical degree at OU, College of Medicine, and then also obtained a master's in public health with a focus in epi at the College of Public Health, and moved after that. I did the standard route. I completed a general psychiatry residency program. My interest clinically, as well as research-wise, has always been with the SMI population, so the seriously mentally ill. And that's how I found myself in Illinois. I was in Springfield, Illinois. I was there for about a year, and then I discovered this opportunity at Oklahoma State University in Tulsa, which was more in line with my career goals in that it had an academic component and still had a sick population and also had research opportunities. So that's how I made my way back.
Wow, so much to unpack there. So, congrats on all of your achievements. And I imagine even just culturally, what you're doing right now and, moving from here and just all of the implications. So, congrats on all of that. What is there anything special about Springfield, Illinois? When you mentioned SMI, did they have a higher population of SMI, or what's special about Springfield, Illinois? Never heard that correlation before.
So, good question. Excellent question. So, Springfield, Illinois actually has one of the federal prisons in the US. And so it has a high quantity of forensic psychiatric needs. And then I am not a forensic psychiatrist by training, but I had to learn rapidly and on the job at Andrew McFarland Mental Health Center. The name has now been changed to Elizabeth. That's the importance.
Thank you. And I imagine for researchers, having access to those population convenience sampling will be very, very helpful to kind of estimate some prevalence and potentially roll out some interventions. Growing up in Lahore, Pakistan, and all of that, were there some certain events in your life that kind of pushed you towards medicine, especially psychiatric medicine as well, or psychiatry?
I was I was relatively open about medicine versus something else. I know I liked science, and I know I liked working with my hands in science. Um, and then in terms of psychiatry, I was actually split between other options and psychiatry, but it ended up being a positive experience at the Oklahoma City Crisis
Mm, mm,
Center, so
mm.
OTRIP in Oklahoma City Crisis Care Center in Oklahoma City, and a great mentor. And I had a patient who was very sick with schizophrenia at the time. That kind of, you know, and made the decision for me.
Thank you for that. And it's very spot on how you talked about mentoring, which we'll explore later on. So, you also have a degree in public health with a focus on epidemiology. I imagine going to medical school wasn't like a walk in the park. What inspired you to go get another degree in public health, especially one focused on epidemiology? And how do you intersect that with psychiatry?
So that's also a very good question. I've learned after I've graduated that there are a lot of opportunities that this MPH opens for me. Specifically, when I was interviewing for jobs, a lot of the interviewers were interested in how the MPH in epidemiology, how I plan to use that in my career. And I know that in my previous roles, I've been asked to kind of take on more responsibilities in the program development, program evaluation
Yeah.
side of things, by virtue of my MPH. And psychiatry as something that has a great community
Mhm.
impact. And I've so far learned that my skills that I've gained, my knowledge that I've gained from my degree, the MPH in epidemiology, has been quite helpful
I
there.
see. Well, thank you. So, for those who might be listening, maybe those that might be in the early phase of college, or people from your path, like could be those wanting to pursue medicine, or someone listening from a remote part of Pakistan or India or Nigeria. Actually, for young girls, what would be some just words of encouragement to kind of keep pushing towards their goal? Because I imagine you experienced a lot of there were so many challenges getting where you are, which we'll still talk about in a bit. But what would be some kind of words of encouragement for people listening?
I would say that what was helpful for me to learn over the years is to go easy on yourself, be kind to yourself, practice some self compassion.
That's very straight to the point. Thank you for that. Now, let's talk a little bit about re-engaging with research. You did mention that in your bio. What was that about, and what would be your goals in this regard?
You know, it, it had sounded, really idealistic that I would have a impactful research career, I would be a good clinician, and I would be a great teacher. This kind of is the trifecta that I was looking for in a job and what OSU offers me. But in reality, I've fallen kind of quite behind, and I haven't been able to take advantage of the collaborative opportunities available. Individuals have reached out to me um, about ongoing clinical trials and wanting to publish and wanting to just have these conversations, but I haven't been able to take advantage of that. And as the year has gone on, since this is my first year at OSU Tulsa, OSU, I've kind of realizing that I should get more serious about um, furthering my research career.
Wow. Well, congrats, by the way, on your position. So you just started your role at OSU, it seems.
Yes, I started in January of
Wow,
this.
congrats. I imagine that as a newly hired or new hire, um, it's really maybe taking a lot to kind of get comfortable in your role, and then even begin your work. Are you at liberty to tell us what your job description is?
Yes, the official title is Clinical Associate Professor in Department of Psychiatry and Behavioral Medicine. And I'll honestly answer your question. Um, it's been a
Mm.
hard transition. It's still actually quite difficult, unexpectedly. Um, there are a variety of reasons, theories as to why it's been hard to adjust to this job. But I'm still very much trying to find my footing.
Mm. What would you say is the hardest beat for you?
Again, to be completely honest, I think that the interpersonal interactions and the political environment of Tulsa Center of Behavioral Health is a state facility. That's where I'm physically
Mm.
based. But my employer is Oklahoma State University,
uh
OSU, and their residents and their students
Rotate through. Yeah.
work
Mm.
under me at TCBH. So that a dual role, however you would like to describe it, has created difficulty. But I'm continuing to work on it. I have support from from individuals on both sides. So it'll get better. It's just
Yeah,
taking a
yeah.
while.
Well, if it's a learning consolation, not to minimize what you're going through, but I know that with most people, and even from my experience, starting a new position comes with a lot of adjustment. But with time, and it also sounds like you have a lot of support, you finally find your foot, your ground, your standing, and then you kind of find your path. So just give it time. It could be growing pains and just trying to adjust to a totally different environment.
Well, thank you.
Yeah, you're welcome. So let's talk about your research. Your research interests include treatment refractory psychotic symptoms in individuals with schizophrenia. How would you explain your research to a fifth grader, and what's the implication of your research?
Fifth grader, you said?
Yes, yeah, yeah.
I would say some people can get sick and they think about things differently, and I find that interesting. And I want to learn more about such people the inform- because that'll help us all develop better treatments.
Oh, that is so beautiful. And I imagine that I guess for me, what I'm also curious to find out from you would be why schizophrenia, right? Um, so personality disorders, you're the expert when it comes to this. You have different kinds. There's the avoidant. There's the I think they have the clusters ABC, and of all the clusters and even the subtypes within them, what exactly about schizophrenia got you interested in exploring?
Right. I it so generally we all, at least in medicine, have a predisposition or a liking towards acute conditions versus chronic
Chronic
conditions.
ones,
Some, and
yeah.
then further going along those lines, some of us like to see short-term results and don't find it gratifying at all to wait and wait and wait years to see if the patient gets better. Some of us, and and then some of this is reversed. So we all have our own. You mentioned personality disorder, so we all have a
Yeah.
personality. So my personality is such that I am more drawn to people who are debilitated or
Mm.
really, really ill. Um,
Mm.
and the official title category for that is SMI, serious mental
Yeah,
illness.
stress and mental illness, yeah.
The
Mm.
way that looks in psychiatry, the bread and butter of my job, inpatient psychiatry, anywhere is 3 big diagnoses: major depressive disorder, bipolar disorder, and
And
then
schizophrenia.
schizophrenia or psychotic disorders in general. Of those three, I'll be the first to admit I have a difficult time interacting with and treating individuals who are manic, who have bipolar disorder.
Mm.
Of course, I see them every day. Half of my list right now is people who have some version of bipolar. Major depressive disorder is a complicated illness in that it is the most psychosocial of the illnesses. And in this day and age, it's depression,
Is
unfortunately,
acceptable in a way. Oh yeah, I have depression, right? People just say it.
right? And then also, unfortunately, in this country, has become quite medical legal. So
Yeah.
people, I'm having thoughts of killing myself. Next thing you know, the cops are there and they're being cuffed, and they're so I have some trouble with that. So with psychotic spectrum disorders or schizophrenia, they're typically, if they have positive symptoms, an example of which is delusions, more others are hallucinations, and they're able to be put on the correct medication regimen, they're able to have cognitive rehabilitation, they can go on to be, quite
Well, just
functional
that.
and
Yeah.
live happy, fulfilling lives. So they're not usually quite violent. That's
Hmm.
actually a misconception in the media. Hollywood is to blame for
Oh
the
yeah. Yeah.
picture of the crazy person carrying a
Yeah.
knife.
Yeah. Yeah. They're often even more likely to be the victims of crimes.
Yeah, you're absolutely right.
Yeah. Yeah.
Um,
Yeah. Yeah.
and going back to my third year experience, which actually third year medical student experience, which brought me into the field to begin with, the individual I'm referencing at the time at the Oklahoma Crisis Care Center in Oklahoma City was a young female, 19, 20, had been relatively functional, underwent some trauma involving sex trafficking, and then
Mm.
and then had developed symptoms such that she was hallucinating, etc., for 6 months. You need 6 months
Mm.
to develop
Mm.
to be given a diagnosis of schizophrenia. And then, so I saw how this my mentor, Dr. Reader, is her name. I'm not sure where she is now. The way with which she approached this young female, and not just medication wise and not just her own clinical intervention, but involving the community supports, the case managers of the safe house she was going to live at, um, uh, the nurses, etc., and involved me, I believe, changed this woman's life. Because what was going to happen if this woman had not come into Oklahoma Crisis Care Center, she would have been on the streets and been taken advantage of by unkind people like she already had. And anytime, if she even thought of reporting it, her disease, her mental illness would be so severe that every police officer, every judge, or every etc. would call her crazy. She's delusional. And she was quite sick. She was
Mm.
delusional. So what we
Mm.
did, we got her on correct medication, and she was able to get to the point where she could have a rational conversation, could separate what happened and what didn't
From.
happen. So
Yeah.
psychosis is basically being out of touch with reality. So her reality then, as a result of our intervention, became more and more in line with what we would call normal. She went from being aggressive in the sense that she would start making accusations when we went and talked to her. You're doing
Mm.
this to me, you're doing that to me. Paranoia, persecutory
Mm.
delusions, if you want to use words. She
Mm.
she went from all of that being actually quite sad and, oh, this is what's happened to me. I'm just 20. I don't know, exactly how this happened. She became much more likely to take her medication by mouth. We do have a system in inpatient psychiatry of restraining patients for the safety of themselves or others. There can be physical
Yeah.
restraints and chemical restraints. So we gradually moved away from this restraint process. She began orally taking her medicines, and then I was there for 4 weeks, I think, and then by the time I was leaving, the team had moved towards getting her into a safe house, getting her sheltered employment, etc. So I believe that intervention of someone who had developed schizophrenia at a young age changed that woman's life.
Wow. Thanks for sharing that. Thank you so much for sharing that. Man, I can't even imagine just um how much work it goes into getting your work done. It's not just the research aspect of it, but also the clinical aspect of it, right? And so let's switch gears a little bit to talk about the research part of it, because it seems like you're trying to merge those two at this phase of your life. If you could get funded for your research without having to worry about the stress of having to go through grant writing and hoping to get funded, what's your most burning research question that you like to address through a funded grant at this moment?
Generally, I would like to see if we can better treat, aka have less relapse for individuals with schizophrenia, to have them return to their baseline functionality quicker and less hospitalization. Now, the intervention, may that be medication or electroconvulsive shock therapy, ECT, or transcranial magnetic stimulation, TMS, or a combination thereof. I'm wanting to find the magic balance of that. So there's less reduction in quality of life, less disability. These individuals can have happy, healthy families like you and I have,
Yeah.
fulfilling jobs, and less less involvement in the criminal system. They go to jail
Yeah.
and they're just in
Yeah.
jail. So jail to
Mm-hmm.
homeless shelter to hospital. I'm trying to break that cycle.
That's a sad bit of it. Um, I have a strong suspicion that my very next question is something you can maybe relate to, because I think our cultures are similar. I'm Nigerian born, moved to the US a while ago, a lot later than you did when you moved from Pakistan here. And I know in both of our cultures, there's a lot of stigma around mental health. It's getting better, as far as acceptance. But how do you harmonize that? Because I'm Nigerian, but I live in the US, so I'm not American. But I've seen a lot of cultural shift in my head. I'm more accepting of some things than I would have been if I was in Nigeria. But how do you harmonize that aspect of being culturally Pakistani, and especially within your community where there's not a lot of acceptance of mental health issues, and even maybe being on meds for mental health? How are you able to navigate those two parts of you?
Thank you for asking that question. I don't know if someone else were interviewing me or doing this podcast if they would have, but I'm grateful
Thank
for
you.
asking that question. So this is something that if I start talking about, you and I will be talking till the end of days. So I will I will just try my best. It's complicated.
Mm,
It's very hard to harmonize that. As an immigrant whose nuclear family is in the United States, who spent her formative years in Pakistan, and has a strong connection to the country, and then now is in the field daily working to improve outcomes and quality of life for Oklahomans, it becomes challenging to reconcile or harmonize, to use your words, that
yeah.
cultural difference of where I came from and where I currently am. That's difficult. I wouldn't say that I've had any success with it. I would say that It's something I'm always trying to trying to find people to talk about with. So regarding stigma, I would say that there's actually a fair amount of stigma about psychiatry and mental health in the US. It's unfortunate, but there's more and more of that coming up. Rural Oklahoma, for example, the rural part of the state is also needs quite a lot of education. In that regard, I would say is actually quite similar to Lahore, Pakistan, which we consider a third world country, poor, etc. The community. There is a solid, undeniable lack of respect and credibility for individuals who are psychiatrists. We do not enjoy the same privileges as our
surgeons,
our counterparts who are internists, pediatricians, general surgeons, etc. Even though there are quite a bit of psychiatrists, and I'm talking about the immigrant population, so those individuals who have settled in the United States, in Oklahoma specifically. So again, this ecosystem, this microculture, however you want to describe it, becomes how to deal or how to assimilate. Again, becomes one of compromises and coping. So I continue to find good people to surround myself with, try to do my best, and understand when to say no, and have strong boundaries and strong lines that I'm not willing to cross. And that's a general answer, but the topic is near and dear to my heart. It's hard to talk about as well because it's not something that's academic to me. It's a lived experience. So again, I would just thank you for asking the question. I think it's an important one.
Oh, yeah. And thanks for attempting to answer it. I didn't think it was going to be a perfect answer, but I just noted that observation as we were talking because I can relate to some aspects of that, like how your practice kind of even evolves because there's so much in your country that you can help out with, but that it's a different kind of what's the word, framework, and you have that passion and you have just this drive to help as many people as you can, and you just wish that it was just so easy to cut those two things across. So but thanks for attempting to answer that. And I can definitely see all of the empathy that comes with you and just how very passionate you are, especially for those who have been mislabeled and cast aside in society. So thanks for all you do. Let's just keep exploring your story so far. Do you have a family, by the way? Are you married? Do you have kids, or you by yourself?
Nope, I have 2 dogs, a cat, and a hedgehog.
A hedgehog?
You heard me.
Okay. I don't think I've ever met anyone with a hedgehog. Tell me. So what's your hedgehog's name?
His full name is Tagwick Kimberly Sonic. And he goes by Tag. He's actually an African pygmy hedgehog.
I don't even know they had subtypes. I bet you're not going to be playing a game of tag anytime soon with Tag. Why a hedgehog? And how do you keep them alive?
Oh, thankfully, I've had no problem with that.
Knock on wood.
Actually, I'm grateful because I had learned about it, read up on it, that their lifespan is between 4 and 6 years. And he's currently...
Did you say 60 years?
No, 4 and 6.
Oh, I'm like 60 years. I ain't keeping no pet for 60 years. Oh, 6 years. Okay, got it.
So he's currently 5 years old. So when I moved to Tulsa, they don't have preventive health like we do for cats and dogs, vaccines.
We don't even have for human beings. So this is the US. The healthcare system isn't very robust. But sorry, I digress.
So
go ahead.
when I took him to the exotic vet, I was just asking. The lifespan I've heard is between 4 and 6 years. He's 5 years old. What should I be expecting? And the gentleman, the vet, said, well, this hedgehog Tag is in very good health. He's not obese. You're taking very good care of him. And I've seen um, such healthy hedgehogs live till about 10. So that made me very happy.
That's good. That's good. Why hedgehogs in particular? Are those animals you like? I just,
So so this is the wrong answer to give, and I'm sure that a lot of people who are more knowledgeable about hedgehogs and manage to listen to this podcast will be unhappy, but I will still give the correct reason. I thought that hedgehogs, from all the Instagram things I was looking at in residency, looked very cute and cuddly. However, I have since learned they are solitary animals and are not really cuddly.
No.
In general. Now
the spikes. They have spikes.
My hedgehog is, I handle him, right? So I've handled him from birth. So with me, he's cuddly and he'll walk on me and sleep on me and all of that. But yeah, he knows my scent. So at night when I unlock his cage, he'll crawl into my room.
What?
Yeah, he comes by himself and will come by my bed and I'll pick him up. So.
And the dogs and cat don't bother Tag?
No, because he has spikes. So.
Got it.
I have a puppy when my mixed breed dog. I had him when he was a puppy, and he's just extremely energetic, and he's always trying to paw Tag and mouth him, and then he has spikes. So now
and learn the hard way. Yeah. I just thought of, if you don't want people bugging you, just grow spikes. That's like a good defense mechanism. I should put that down on my to-do list. Grow more spikes. Well, thanks for sharing that. But I guess what was driving at was just self-care tips you have. You're female, you're a minority. I can use that word because I'm a minority as well. You're occupying a space that is sometimes often controversial, because psychiatry as a branch of medicine has gone through so many issues of acceptance and public, acceptance, especially to be here. What are some ways you're taking care of? And then you work with the mind, which is, can be quite as abstract, right? But it's so important because that's like the seat of judgment for so many things. And it's very important to, and then you work with even the minority of the minority, which are SMI population. How do you take care of yourself?
To be very concrete, I maintain my faith. So I'm Muslim. I try to. We're supposed to offer prayers 5 times a day.
5 times a day, yeah.
I do as much as I can. So I maintain my faith. And then the other more concrete things I do is I like taking baths.
Okay.
So the bath, the bubble bath, I was looking at there's a whole world of self-care that has capitalized and commercialized. On
USA, yay!
on the concept, and I'm very much sucked into it. But so I like baths. I like to go to spas. I like to go to, like, if I'm going on a vacation or getting an Airbnb, I will try to go to a place that has a hot tub. I have pets. I have dogs. They're young dogs, so I go out in Tulsa, close to the Turkey Mountain area. I go hike with them. I spend a lot of time with my pets. It's proven to be therapeutic. Clinically, for dogs, the therapeutic relationship with humans. And I offer my prayers, and when things get hard, which they often are, I use that to care for myself.
Okay, I like that. So your religion and spirituality and some other practical things like baths, spas, just taking care of yourself. Good. Your current role, you mentioned earlier on about working with residents. So I imagine there's some form of experiential teaching you have to do as part of the job.
Absolutely. I have Yeah, I mean, it's a residency program,
Yes.
and I'm
Yeah.
the associate program director of the
Oh,
residency
wow.
program.
Wow. 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 Do you have some didactic teachings as well, like in a classroom? Well,
Absolutely, I teach the residents in formal classroom setting. I teach the medical students in a formal classroom setting, and then every day I teach the residents clinically, so on
yeah.
rounds, ward rounds.
Yeah, yeah, yeah. Now, as someone who's undergone additional postgraduate training in medical education, and also with your advanced degree in public health, what insight can you share about effective teaching methods or strategies for people who are in the field of psychiatry, for educators in the field of psychiatry? Yeah.
I really learned about how much there is to that question after I completed my training to teach in medicine, the certificate program that I was referencing as the additional postgraduate
Mm-hmm.
medical training. It was a 6 month program, completely virtual through Harvard Medical School. And I've learned just the depth to that question. And to be completely honest with you, I still am, as relatively junior faculty. I'm finding my style. I'm finding things that work and some don't. And I've learned to accept the caveat that what works for resident A, resident B will completely
Mm,
dislike. But
mm, mm.
so that, again, as junior faculty, also personality. Sometimes I find myself struggling with negative feedback or
Yeah.
complaints about myself, but just learning that's going to be a part of life. But some things that I've learned that are helpful is transparency. So I I do my best to be direct in my expectations of my learners, certainly in the goals and objectives of my lectures, and then circling back, touching back, but trying to touch base at the end of a module or a month. Well, were you able to learn what I thought
Mm.
you'd learned? And if not, please provide me feedback. And residents sometimes are scared to do that. They fear, no, I'm there attending, I may retaliate. In that sense, there's not much I can do. But students, my medical students who rotate with me, have been really good about giving me good feedback. So I think what's been helpful to me that I've learned from that course is that there are different styles, and I'm still experimenting with that. But on my day to day, I've learned it's helpful to be direct with learners.
I like that transparency and being direct. Good. Now, if you could switch roles with any fictional psychiatrist or epidemiologist from literature or film, who would it be and what would you like to experience in their shoes?
Oh no, this is an interesting question because I still feel like all the psychiatrists in movies have been excessively glamorized. I don't know. I I'll have to think about that one. I would say if I had to switch someone who's fictional, top of my head, nothing comes to mind. I'll have to think about it because I just generally haven't felt I've seen anyone
Connected,
with whom
yeah.
I can
Yeah.
relate. It's always they're doing something good, but it's unrealistic, or they're
Yeah.
using their power.
Oh, exaggerated for for viewing purposes, right?
Yeah,
That's
exactly.
okay. That's okay. Let's still stay within the time travel. So if you could travel back in time to give your younger self one piece of advice related to your career, knowing everything you know now and given that hindsight is 2020, what would it be?
Calm down.
Ah!
Just because, like you said, hindsight is 2020, so I can say this
yeah.
now. But
Mm,
just the amount of stress and self-created anxiety that a lot of us put on ourselves. It's been more and more research comes out every day about the negative effects of chronic inflammation or chronic stress on the human
Stress.
body.
Yeah.
And then,
Yeah. Yeah.
there's functional MRI studies to look at different areas of the brain, and then
Yeah.
the
Yeah.
association of that with cortisol spikes. I mean, this is all knowledge that I have now, but even anecdotally, if I weren't aware of this research evidence, I think I would have I would tell my younger self to go to that concert you're going to skip because you have to study, or I mean these types of things, just do them.
I like that. Um, Calm down. And I think earlier on you had said being going easy on oneself, so that's just I like just tying those 2 points. It's really been very nice chatting with you. I have learned a lot about you, and your passion for just what you do shines through. So I have no doubt that even in your current role, though there's still a bit of adjustment process going on, I have no doubt you find your foot and you keep breaking, more grounds. I just want to say thank you so much for your time today, for sharing of your work, of your passion, and of yourself. I've learned more about hedgehogs than I thought I could ever learn. And so wishing you and your hedgehog long, long life.
Thank you. That
and
means
then
a
all of the
lot to
good
me.
things in between. And thank you for all you do. And it's the idea behind this podcast was really to diversify the voices, and definitely your unique niche of psychiatry and epidemiology. I think that's very, very unique. And so thank you for filling that niche. And before you go, lastly, what inspired you to come on the podcast today? And are there other things you like to talk about that we haven't explored yet before we go?
I thought that why did I come on this podcast?
Yeah.
I'm on y'all's emails or email lists, etc., and I keep seeing that, oh, the College of Public Health is doing this, the College of Public Health is doing that. And I know that Dr. Julie Stoner passed away unexpectedly, and then there's just a
Yeah.
lot that I've been hearing about the College of Public Health. So, and I had a good experience with. I think you all have some really admirable educators, um, educators on staff. So I thought this podcast was cool. I thought it had a good mission, and I thought that I would try to get my 15 minutes.
Thank you. And I hope it was worth it too for you. I hope you enjoyed your time here. In any event, thank you once again. And if you ever want to come back and maybe talk about more stuff and expand on what we're talking about today, always please reach out. Do not hesitate to reach out. I just want to say thank you so much for joining today. And thank you,
Okay.
Dr.
Thank you.
Sarfraz. All right. Well, enjoy the rest of your weekend. All right. Bye. Wow. So that was the podcast, the GROklahoma podcast show. If you love this episode, there's plenty more where that came from. Check us out on Instagram at the GROklahoma podcast. And we are also on Podbean. That's our official podcast listening app. But you can get a podcast on any other platform. And if you'd like to be a part of the podcast, just reach out. Our email address and contact information will be in the show notes. In any event, my name is Dr. Ogunsanya from the OSCTR, and thank you for tuning in today. Bye.